Good afternoon. I'm Mitch Rotholtz, Chief of Governance and State Affiliates, as well as Executive Director for the APhA Foundation, and I welcome you to this unique webinar for us. This will be one that will have breaking news, and I mean breaking news. The ACIP meeting is still going on, so we don't know what their votes are, but as soon as we get them, we will share them with you. And so that's what makes this a unique and timely webinar. Today, we've scheduled this to help discuss some of the breaking updates and information for you to help prepare how you're going to deal with booster doses, including recommendations for use and considerations related to the authority. Recently, you heard the FDA release its authority, and now ACIP is dealing with it. And we have with us today to walk through the discussion are two of our vaccine experts, long-time workhorses in the area of immunizations. Our first is our APhA's liaison representative to ACIP, who's been sitting in on the last 2 days of meetings, listening to all of the research. Steve is a retired captain from the U.S. Public Health Service, as well as a professor from the University of Tennessee College of Pharmacy. He's a nationally known faculty member, as well as writer of APhA's pharmacy-based immunization certificate training program, as well as he has personally trained thousands of pharmacists and pharmacy staff, including students and technicians, and has also in Tennessee administered more than 10,000 Tennesseans against vaccine preventable diseases. Our second speaker is somebody who's known to everybody on this call, is John Gravenstein. John is the Director for Scientific Communications with the Immunization Action Coalition and is president of Vaccine Dynamics. John is globally recognized as a vaccinologist, a pharmacist, epidemiologist, and the father of pharmacy-based immunizations. He's written more than 300 articles and 11 books, primarily on the topic of immunizations, public health, and leadership. And he focuses on implementation and interpersonal dynamics in regards to healthcare, but other leadership development activities. Recently, John was awarded the profession's highest honor, the Remington Honor Medal, which he received in 2020. And again, this is the most distinguished honor in the profession, and we're proud to have John and Steve with us for this special webinar for today. In addition to our two vaccine experts, we also have from the APhA staff, Dan Zlot. Dr. Zlot is the Senior VP of Education and Business Development with APhA and has had more than 10 years of experience at NIH in the oncology and infectious disease specialist. He's our clinical guy when you have information requests regarding monoclonal antibodies or other clinical information. Dan's the guy who we turn to. And also with us today is Michael Baxter, our Senior Director for Regulatory Affairs at APhA, and also Meg Freda, our Senior Manager of Pharmacy Practice at APhA. Each of them will be responding and available to respond to questions from the audience. So we did the introduction, we've introduced our panelists. We will have our open forum. We'll have some questions of the panelists and then open it up for questions that you have from the audience. And then the last 10 minutes of the webinar, we'll talk about ongoing activities and what's coming up at APhA. Just want to go over some of the ground rules. If you have questions, please enter your questions in the question field. We will try to get through as many questions as we can, as well as we have in the handout section of the GoToWebinar, there will be the current handout that will be, of course, be updated as we get information as we move through this webinar, and we will share an updated version of that handout post-webinar with you. Next slide, please. Okay, so now we're going to jump right into the session of talking with Steve and John about what's going on. So if I could ask Steve and John to join me with turning on their video. Welcome, guys, and I think the three of us, as well as others, have been closely watching the discussion of ACIP. The meeting was supposed to end at 3:30, and it's running over. So let's give a perspective in terms of, how do we get here? What's happened to get to this point of these discussions that are happening at ACIP. So, we heard what happens at FDA. We've heard in the media what that means for different perspectives. But from your guys being involved integrally in following this and engaged in the discussions, help our audience understand the process that we are going through, coming up with the decisions that will come out later today. Steve, I think you're on mute.
So I've got an earphone in listening to the vote at the ACIP. So try and do double duty. Last Friday, FDA's advisors, answered questions for FDA, and then if you read the news last night, FDA expanded the EUA only for one of the brands for the Pfizer BioNTech COVID-19 vaccine. That's the regulatory status, and it's very, it's fairly narrow. And as we speak, CDC and its advisors are trying to figure out how to operationalize it. And it's been, it's a committee, and people say things in committees that are interesting, especially when they're being broadcast around the world. But right now, they've just voted to adopt 2 of 4 proposals, and we'll get to that eventually. But as we speak, your highway tax dollars are paying these folks to work out operational guidelines.
Okay, so let's talk in terms of the policy questions that ACIP started with in this discussion. Give the audience some perspective of where did they come into this discussion before they started doing these votes. Where did they start?
Well, we started, and by the way, you have to pardon me because I'm a little brain fried here after being sitting here for 2 days watching this kind of stuff. But we started talking about safety and immunogenicity of a 3rd dose for the vaccine. I'm trying to get over here to my thing. So really, we talked, and there was very little data that's on that. I mean, they're talking about the phase 1 data, which is 23 people, and then the phase 3 data, which was like 300 people. So not a lot of data to look at. And so then, by the way, we did have an excellent presentation there on immunogenicity. I wish we could actually include that in our course. It was just a great presentation on that. But we went through that, and they talked a little bit about cellular and humoral immunity, and that we appear to have some waning of immunity in certain individuals. Again, the data is scarce over time. And so it's primarily with aging, and also we talked about the variants too. But it's probably more aging and not in everybody. So the vaccine effectiveness discussion was talked about. We are not seeing waning of infection or protection against hospitalization and death. It really is holding on there. What we're talking about is sort of waning against infection. And so, we went through some of those details. We talked about nursing home residents, and the interesting fact about nursing home residents was the fact that the protection of the patients is not the big issue. The biggest problem we have with that nursing home patients is the fact that the workers aren't getting vaccinated. So bottom line on everything we've talked about is primary series is far more important than a booster series, and we're just trying to figure out what's going on. And I've got everything blasting here at once, but that's pretty much a summary of that. After all these discussions, they've come up with 4 or 5 different votes that they're voting on. So that's where they're at right now.
So we'll go through those 4 as they're going through there. But in terms of the number of individuals, if they go with the trying to determine, are we going more than 65 years or older, or what's the age? Help us get a little perspective of what are we talking about of vaccination opportunities or load that the community will be dealing with.
Right. So this table shows how many folks are now 6 months beyond completing their primary series. And so if you look at the total column or the total row, 26 million have gotten are 6 months past dose 2 of their Pfizer BioNTech, 23 million after Moderna, 3.3 million after Janssen. And so those are the folks in question today. And then you see the rows stratified by age. And what's clearest is that there is waning of protection against hospitalization. And everybody's saying that's the most important thing, not waning against just any old infection, but waning against hospitalization, severe cases. And that's 13 million Pfizer, 13 million Moderna, 0.8 million Janssen. Now, what the situation is that FDA has acted yesterday on Pfizer BioNTech only. That's we're back where we were in December of having an action on one of the brands but not the others. And so what I found very interesting yesterday was the graphs of showing a little bit of waning against hospitalization were more prominent with Pfizer than they were with Moderna's brand. And so, depending on how these votes go, we might be making, the audience, might be making offers of boosters to the Pfizer column people only. And it's okay because the Moderna column people, you can reassure them, you're in a better shape, all in all, because your immunity is holding up better, not waning, than in the Pfizer case.
I want to add to that too, John. The main thing that what John just pointed out is the fact that they're only going to vote this today on using Pfizer vaccine following Pfizer primary series. If you do not follow those rules, you are actually against the PrEP Act. And since this is an emergency use authorization again, this is not, you would not be covered under the PrEP Act if you do not follow the rules that they say on that. And let me tell you the reason it came out this way. When Pfizer actually went to the FDA to approve this vaccine, they asked for 18 or 16 years and up for everybody. And so the FDA denied that. And so the only way that they could, and that's what they had to act on, was that particular application. And so what they did is the FDA then went back and amended the emergency use authorization so they could include certain groups, which is being determined now as we're speaking. So that was the main effort on that part.
So let's step back a second and take a quick look. The guidance that ACIP is working under. It starts with the FDA EUA. Let's look at what the FDA released yesterday and give some insights. In some of the discussions at ACIP, it was like, what type of individuals would fall under this authorization? So let's talk. I don't know, Steve or John, if you want to talk about what FDA did, and then where was the ACIP discussion, and particularly one question I know a lot of in our audience are going to be interested in is, how do pharmacists fall into that in the discussions? Where do you sense ACIP is going to land potentially? Although they may be voting and make a decision before we're done, where do you think they're going to land in terms of pharmacists and other healthcare workers? So let's start with what the FDA did first, then move into that perspective.
Right. So FDA evaluated a big stack of study results that Pfizer presented to them, Pfizer and BioNTech presented to them, showing the response to a third dose in generally healthy, not immunocompromised people, and of mixed ages. And I think it was actually 8 months after. No, sorry, it was 6 months after primary series. And so FDA has said, okay, fine, we agree. There is restoration of antibody. That you have goosed up, you have boosted up the antibody levels to higher levels, and so we approve. We agree that you can. We're going to expand the EUA, and remember, this is the product that's some uses are licensed, fully licensed. Some uses are under the EUA. The boosting part is under the EUA, and so that's what the FDA did.
Okay. Steve, any perspective in terms of the discussion from ACIP? right now they're voting on individuals with medical conditions. But from a healthcare worker, any sense on where they may land on that one?
The problem was that we had some people on the committee, the voting members, who basically said that we're not showing loss of protection in people who are, and again, this is based on lack of data for things, but for what data we've seen, we're not seeing loss of protection or waning immunity in people that are younger. And so, while, I'm not even going to talk about breakthrough because we're always going to have some breakthrough type of stuff. And by the way, that's worth mentioning. The one thing that they did mention during this whole thing was the fact that since this is a type of virus that affects respiratory mucous membranes, you have to expect that there's no sterility occurred by a vaccine. It's not going to protect you.
Sterilizing immunity.
Yeah. So you're not going to kill all of the virus and prevent it. So you're actually going to have, everybody's got the potential for a mild case of disease. And what they brought out is that if you do even have a mild, that's why some people say they got cultured and they were positive even though they have no symptoms. But keep in mind that you can still spread the virus if you were in that particular situation. But really what they said, they're pretty well unanimous on this over 65 group. And they may have already voted on that, I don't know. But there's 4 votes going on right now, and they've taken and broken these things out. So the different votes that they've looked at are, like I said, the 65 type of vote. Then they're looking at age differences, because they said now there's some evidence that 50 to 64 years might be needed instead of 18 to 64 years. So let's try that. And then they broke it down into 18-year-olds so they could include people who are potentially occupational exposed or have medical conditions that are exposed. And the people, as they're during discussions, are all over the board on what they believe should be done in this part. So, and I'm assuming the voting's going on now. So,
okay. So to help the audience understand the difference and what impact this decision may have on the additional dose that was already authorized and the booster dose. What's the difference between the two? And are we going to see a merging of terminology, or is this decision that's going to happen today going to influence what we do in that left-hand column on additional doses?
not at all. In fact, the discussions on that part were very minimal as far as that. They kept bringing it up that we still have an additional dose in certain individuals, and they did not talk about boosting those individuals either. But again, as John mentioned, we're talking about people who are at least 6 months out from the initial dose. And so that, since the third dose came out much later than that, it's going to be a while before we actually get to that point. So these are going to come out written as interim recommendations. They're not going to be solid because of the fact that we're waiting on more data. We're looking at younger kids coming out. They're going to look. The NIH is doing studies on mixing and matching also the vaccines, but those are not out there yet. So this is more stuff to come on this. I will tell you that there was a big discussion on this third dose. What do you call it? Is it part of the primary series? Is it the third dose of the primary series? Because on some of our vaccines, if you think about it, it's given 0, 1, 6 months. So this could be the 6 month final series, or is this actually a true booster? Or is it something a true booster might be? We have to give it every year, or all kinds of possibilities. So I just noticed my camera froze.
We can still hear you though.
Okay.
Thanks, Steve. So in terms of timing, so the recommendation that's coming out is a 6 month time frame. On those who were immunocompromised, it was a 28-day timing. Any insights?
Minimum, by the way, Mitch.
That was where my next part of it was going. So you're reading my mind, Steve. So we got the 28-day, 6 months or more. Could you give a little more insights in terms of the timing? The 28-day and 6 months, before 6 months, after 6 months. What was this discussion around that?
Basically, we're operating on no study data. I mean, so when the first booster came out, they realized that some of these immunocompromised people were not responding to the first two, and then some of them would respond to the third dose. In this particular case, we're trying to look at a general population type of thing, not individuals that have an issue, and looking to see if what groups of people probably need it. And again, there's not a lot of data out there as they're doing it, so they're trying to figure out what's the best thing to do. And again, I want to point out that they're not even sure that this booster will have much of an effect on the pandemic. It's getting the unvaccinated people vaccinated that could have the biggest effect.
So if I can add to that, with immunocompromised people, it's sort of an issue of they probably didn't, or they may not have responded the first time. So we want to give them an extra dose fairly soon to get it, to get a better initial response. With the big chunk of people we're talking about today, it's more about you had a lot of immunity, but it's come down a little bit. We want to get you back up, and that's a different case where the immunocompromised people never got very high in the first place. And that's why you're waiting. This gets to another point later of when people start showing up on your doors in your pharmacy, you don't want to vaccinate them too soon. You don't want Oklahoma Sooners because you need time for the immune system to mature, to be ready for the third dose for this big chunk of generally healthy folks. So you really want 6 months of time to elapse.
And to add to that point, John, in terms of, there's always this understanding that there's a 4-day window that a provider could utilize in that timing. Could you help the audience understand what that 4-day timing is versus the set 6 month or whatever, or 28-day, 21-day?
It arose from immunization information systems, the computer registries. They needed really specific rules that the computers could use to calculate due dates and what to count and what not to count. And so they ended up picking 4 days as you could be 4 days too soon and have it count on any given date, but before that it wouldn't count, and you'd have to have the dose repeated. So when we start talking about 6 months after the primary series is complete, you can go as soon as 6 times 30 is 180. You can go 156 days and have the dose count, but not 155.
And that 4 days is an exception, not a standard.
Right.
If somebody gets it 4 days earlier, so you count it, but it's not something you should schedule your appointments, right?
That's right. It obviously is a less important point than when you're talking about that 3-week or 4-week interval for dose 2, where 4 days is a big chunk of time. And again, you're waiting to let the body prepare for that next dose. If you give it too soon, you've squandered some of your chance to get immunity.
So give a score update for everybody. So it looks like ACIP has said people over 65 and long-term care facilities.
Can you go back in the slides to the three policy questions? Yeah, thank you. So they voted yes on one, and they divided question 2 into 2 halves. So you will soon see that the newspapers say that CDC has agreed that people over 65 and over, and long-term care residents, regardless of age, should get, who got Pfizer-BioNTech the first time, should get an additional, which is third dose of Pfizer-BioNTech 6 months after the completion of the series. And we've got screenshots, but we haven't had a chance to get them cleaned up to project. But we will do our best to revise the handout, and you'll see in other APHA communications the precise language. So that was unanimous to adopt policy question 1. They split policy question 2 into 2 halves. Basically, everybody 50 to 64 at risk of disease should get with underlying medical conditions, and that's going to be a laundry list. But heart and lung and diabetes and kidney and all that kind of stuff should get the third dose. So that was 50 to 64. Then they had a wishy-washy based on individual benefit and risk to be defined for 18 to 49. They adopted that one 9 to 6. So it was less unanimity, but still a positive vote. And they're debating policy question 3, which will be the vote number 4 right now.
And thanks, John, for the up to date.
I'll get you the next score when you take the next break.
But the key on that one too, on the last one that John talked about, is that was their attempt to quote do shared clinical decision making, but not call it that. But do not get mixed up that pharmacists can't make the decision in terms of somebody who has medical risk and would benefit from the vaccine. You as healthcare practitioners have the skill set, the knowledge, the ability to have those discussions. They don't have to get an approval from a physician or other prescriber. So I'm going to make sure people are interpreting it the right way, the way it's intended.
I also though would like to add the fact that during the discussions and all, it was pointed out that the doctors that in their doctor's office, they've had patients come in and say, well, I've already gotten my third dose from a pharmacy. And so these were comments of people that are from pharmacists that are apparently not following the rules. And this is what gets us in a lot of trouble when we do that type of thing. Pharmacists have given 70%, that number came out, of all the COVID vaccines now. So we are the most prolific providers that we have out there for it. And we're going to get hammered with this one again, because that's where people are going to go, which is a great thing for you as long as you're not overworked. And I know you are, so that's not necessarily great from that standpoint. However, please follow the rules that they've given on this. But they're not going to be really policing you. You get to determine, like Mitch said, what is that underlying medical condition? It's the individual benefit versus the risk. So follow the basic rules, but when it comes to making that decision, you and the patient make that decision.
One of the other things thanks, Stephen. One of the other things that they mentioned in the discussions today was that these are interim recommendations. So they will be updating them, especially with what goes on with Moderna and what goes on with J&J. Let's talk about though the interchangeability of the brand Pfizer product and the EUA product. Is there a difference, and should we be looking at them any differently? John?
Well, Comirnaty is actually the trade name of the Pfizer product that's approved. So they're the same product. So it's not an issue with that. If you hear that it's like a trade name versus a company name, which was the way that they referred to it before. So no, there's no interchangeability between those two. Now between Pfizer and Moderna, they did say, if you remember, on the booster, or not the booster, the additional third dose for immunocompromised, that you could actually interchange that. But they're specifically saying now for this one, do not interchange them. Only give this to Pfizer people. That was actually one of the reasons some of the voting members said they were not going to vote for it, because they didn't have, it wasn't fair to everybody who got this other stuff. But in this particular case, we're in a pandemic, so fairness is probably less important. And they're discussing these other issues as we speak. So it's still going to come up. But for right now, when someone had a Moderna says they want a booster, you have to tell them no, as John said earlier in the meeting.
And thanks. And one of the other points to bring out from a CDC perspective, CDC's guidance is with the Pfizer vaccines, what you have in stock in your practice is what you use, whether it's the brand or the EUA. They're both the same, as Steve says. Use what you've got in stock. Okay, so let's talk about when patients are getting these boosters. Is there anything that the providers need to communicate to the patient in terms of expectations? Is there additional side effects or anything that should be looked out for in these patients?
Again, there's not been a lot of information from us on third doses, and the information we got from Israel was not really good at all. but they seem to be that the adverse effects that occur are very similar to the second dose as a general rule of thumb. So in the Israel study, they actually had fewer adverse effects in the third dose. However, that may be because of the distance from the first dose to the second dose like we had in the first one. That was pretty close together, the 3-week time period. This being 6 months, we may not see as much reactogenicity to it. We don't know though. We're waiting to see what happens.
Well, we know to the extent of 5 or 10,000 people. We don't know the rare events because it's limited to that size. There was a piece of data tossed out that when they did some general public polling, one of the people who have not yet been vaccinated, 1/3 of them would say, "Oh, boosters? That makes me even less likely to get vaccinated. You guys didn't know what you were doing in the first place, and see, it doesn't work. I mean, that's why you're given more doses, or some argument like that." So the answer to that, who knows whether that would really change people's minds or not. But you need to be ready with the answer for that. And the answer is we're trying to keep the protection as high as we can. And there was really high numbers in the first few months. It's slipping a little, and we're going to catch it before it slips further. And so that's a positive story. And the way you engage in those conversations, of course, is important.
But also they said that those that had the vaccine, 2/3 of the people would actually want a booster dose, so are willing to accept it. So expect that to occur also.
So we're going to go to the audience. If you have questions, please keep on putting them in the Q&A box, and we'll keep on presenting them to our panelists. And ACIP is still meeting everything hasn't been finalized in their discussions. But is there a difference in the dose for these booster doses from what the dose 1 and 2 were?
Sorry, I didn't hear your question, if that was for me.
Is there a difference in the dose that is administered for the booster dose compared to the dose 1 and 2?
A very important point. Be ready for, at the moment, no, but be ready for some changes down the road. Pfizer's booster dose is the same as Pfizer's original dose. That may not be true for Moderna. I don't know what there is in their final packet that FDA will judge. So don't assume, because there's been some talk about a lesser dose for Moderna's booster than for its primary. Oh, by the way, some of the pediatric dosing is going to be a fraction of an adult dose. So be ready for that change. So if you have weekly staff meetings with your COVID team.
And of course, we'll be keeping everybody up to date when those things change as well.
Right.
Other question that came in is Moderna approved for a third dose in immunocompromised patients, but not a booster?
Correct. Its EUA was expanded back in July for immunocompromised. With it, in that additional dose definition, not in a booster dose definition.
Okay. This question I'm actually going to ask Meg Frieder from our team to join us on the screen. What is the reimbursement and coding for these booster doses?
Yeah, so at least for Medicare, the reimbursement rate has been set to be the same for a booster dose as it is for a first dose, second dose, and an additional dose. Where things get a little bit nuanced is with the billing to prescription claims. So the other plans will kind of follow Medicare's lead in terms of reimbursement rates. But then when you're actually submitting that claim, you will want to pay attention to some of the values that you use to clarify which dose is being administered. So you can see for a prescription claim for an additional dose, you'll want to use a value of 7, and for a booster dose, you would use a value of 10. This guidance comes from NCPDP, who sets these standards, and they will be releasing guidance on this, but this is the direction they're headed. And then for those of you that are, doing medical billing, these are just some of the CPT codes to be aware of. You can see, to that question previously, Moderna, you can bill for an additional dose, and there's a code for that. There are some codes set proactively for Moderna in terms of the booster, but right now we're only doing boosters for Pfizer. So that's the reimbursement landscape.
Awesome. Thank you, Meg. So moving on to another question that came in. Does the recommendation of a booster dose change CDC's definition of being fully vaccinated?
That's a great question. And actually, they really pointed out that they were going to stress that no, it does not change it. The primary series, which is still considered 2 doses of the mRNA vaccine, is considered fully vaccinated. And they did that on purpose because they don't want to come down where a company might make their own decision that you're not fully vaccinated if you haven't got the 3rd dose. So definitely the definition is the 2 doses.
Okay, awesome. All right, we got another question in. Does the available data suggest true waning immunity, or could this be lower efficacy that's due to the recent surge of new variants that were not present during the original clinical trials?
Yes, all of the slides that they're considering are posted at the CDC website, cdc.gov/vaccines/ACIP. And you can see there, they sliced and diced the data all sorts of different ways by time to get at Delta dominant times versus earlier times, by age, by vaccine brand, by whole variety of subdivisions. And the best guess is that it is a time effect more than it is a variant effect, and based on a collection of different studies. There probably is a little bit of a mix of both, but it's dominantly time, more apparently time than variant.
There was one thing that really caught my eye during this thing. It's a little bit different from that question, but the number needed to vaccinate was brought up with a booster to prevent 1 hospitalization over a 6-month time period. And for over 65, that number was 481. So you'd have to vaccinate 481 people to prevent 1 hospitalization. But in the 18 to 29 age group, it was 8,738. So that tells you that for the younger group, it's not as urgent, and which is why the votes were separated out as they were. That for your healthy young person, you can convince them they don't need it.
Right. Yeah, and how should you as a professional, how should you spend your time? It would be far better to society if you did some sort of outreach program to completely unvaccinated people and spend an hour or 2 doing that than an hour or 2 doing booster doses. Society needs those unvaccinated people, given their initial protection, far more than it needs booster doses delivered.
So and again, the goal is to prevent severe disease. It's not to prevent infection. It's to prevent hospitalization and death.
Which brings me to the next question that came in: is do we have data that shows the incidence of COVID-19 infection after receiving 2 doses of vaccine? So the breakthrough data, what is that telling us?
Well, again, you have your vaccine effectiveness data that they've demonstrated for it, and it's in the 90s, depending on which study that you look at for the 2 mRNA vaccines. But again, as I mentioned earlier, there's all stages with these and it depends on what you call breakthrough. Just having a positive culture, are you sick? Do you have just upper respiratory infections? Do you have pneumonia? That's varying levels of the whole thing. So if we have someone who we can keep out of the hospital and keep from having a pneumonia, but yet they have a runny nose from the thing, then that's still a success. So you can't expect everybody to be protected. And yes, you will have people that will break through, but from prevention of serious hospitalization and disease, we're looking in the 90s and up percentages.
Yeah, one of those slides I think would help answer that question, which is they showed I think it was something like 10,000 COVID cases, or actually I think it was COVID hospitalizations. So 10,000 COVID hospitalizations, and then they showed two squares. Sorry about that. This one, the big one, was the unvaccinated COVID hospitalizations, and a much smaller square was the vaccinated COVID hospitalizations. Yes, the vaccine is not perfect, but it is far better to get the vaccine than to not be vaccinated. And so just because a vaccinated person gets hospitalized doesn't mean the vaccine doesn't work. You have to look at the population, and that's where you see the value.
And along with it, that graph had on it that you were 22 to 23 more times higher risk of getting hospitalized if you don't have the vaccine. And that's in the ages 18 to 64. You were 13 times more higher in the age of 65 older if you don't get the vaccine. So once again,
so what that means, for every vaccinated hospitalization, there's 13, or there's 22 unvaccinated hospitalizations. Right. So some sniper can say, oh, look, there's a vaccinated person in the hospital. Okay, fine. And then there's 13 or 22 others unvaccinated. Yep. Next to in the hall down the hall.
Dan's not just got on his screen. Dan, you want to add some perspective?
Yeah, I was just going to add, so with regard to the question of what's the incidence of breakthrough infections, there's a lot of different data and there's a lot of different ways to look at it. One of the studies that I've seen most recently that came out that I thought did a nice job of capturing this was an article that came out in the Lancet earlier in September. And this was looking at 1.25 million people who were, this is a prospective case control nested study. You don't have to worry about what all that means. But it was looking at people in the UK who had been vaccinated with either the Pfizer or in this case, the AstraZeneca vaccine, because that's what they're using in the UK. And the breakthrough infection rate in that group of people and in fully vaccinated people was 0.2%. So very, very low in terms of breakthrough infection rates there. And again, there's lots of different ways to look at the data. I think that's one of the better ones out there. You can find slightly different numbers if you look at the full spectrum of data, but that's a good rough estimate, I would say.
Okay, great. So just for clarification, because we're getting a number of questions in terms of duration between injections, could you refresh for the audience the timing between the Pfizer dosing recommendations? So for doses 1 and 2, and then the booster.
Well, between 1 and 2 is 3 weeks or more, whatever. I mean, it doesn't have to be exactly 3 weeks if that's the case, but that's when it is recommended. And then 6 months after the second dose is the earliest, but they also said that 6 months to 12 months. I mean, that was mentioned at one point. So a minimum of 6 months, but it's not bad if it's a longer duration. If someone comes in, you say, well, it's been 12 months. Is that too late? No, it's not too late to do it. You would go ahead and do that at that point.
Okay. Other question that came in is Dr. Mindy McCarthy of Johns Hopkins has said that the second dose of Pfizer should have been administered much further out than 21 days, that in fact, booster doses will now improve immunity and serve more like an appropriate administered second dose.
Yeah, maybe. So, if we think about how many vaccines are given for adults are given at months 0, 1, and 6, right? So the standard, that hepatitis B, hepatitis A is 0 and 6, others. And I mean, that's just such a common thing. You give 2 priming doses, you follow it up with a reinforcing dose a few months later after the lymphocytes have gotten time to get themselves geared up. But that also means that the trial has to run longer. So if that had been, if that was the approach taken, we would have not gotten the vaccines until Easter, April, May, June, something like that. By the time the results were in, And so, yeah, in an alternate universe, that might be, get you a little bit more antibody. But in this case, because of the crisis, it would have delayed the results. And so, yeah, I wish we had better data sooner, or I wish we had perfect data. But under the circumstances, everybody wanted to get prompt immunity to get to start controlling the pandemic, and then we'll figure out the optimized schedule down the road.
And Pfizer approached that during the meeting. They have actually answered that question exactly the same way, as the fact that they wanted to get the highest levels into the community as soon as possible.
Okay, thank you, guys. We're gonna have time for one more question, and the question is: can COVID vaccines be administered during the same visit as an influenza vaccine? And I'll add on top of that, are there additional tips or guidance that you have for the audience in regards to COVID vaccination and other vaccinations? So I'll kind of group it all in our closing comment.
I'm really glad that you brought that up. So the answer to that is yes. They can be given at the same time, give them in different locations, different arms as you do that. And just warn the people about the reactivity of the vaccine, but absolutely don't miss opportunities to do that. We really need this to happen. One of the questions that's come up is can we mix them? And the answer is definitely no. And so, but we're going to get opportunities when people come in for flu, say, have you had your COVID, or vice versa.
Mitch, they have not yet voted. They have not yet taken the fourth vote. Can I give you an update on what the before you start the closing process? Let me give you an update on.
What we're going to do, John, is you give the update right now. We'll do our other items we need to cover, and before we adjourn, I'll come back to you and say, John, anything new? So go ahead.
Can you take the slides back to that policy question 3, 1, 2, 3? They are struggling with this one, and it's the one that involves all of those of you who are under 65 and don't have underlying medical conditions. It's the third one. Should people get a booster dose 18 to 64 just on the basis of occupation, nursing, pharmacy, medicine, et cetera, or setting, prisons, et cetera? And they're struggling with it because those folks should have had a very vigorous response to the primary series. And do they really need boosting? Because there's not particularly evidence that they are waning. And so that's they've been going around and around on this for about 20 minutes now. And so we'll see if they vote by the time you finish the other slides.
And I'm sure they may have brought up during these discussions the fact that the masking and the social distancing are still very important in this whole process.
Yeah, the waning is due to age and health conditions, not are you a frontline worker, because that's not the issue.
Okay, so what we're going to do is we're going to move into the last bits of things we need to cover. John, I'm going to come back to you at the end to give a quick, actually a quick recap.
So we'll go fine.
Okay, so we'll do a quick recap of what they voted on, and so we'll give everybody the latest and greatest. So if we go to the next, I'll now turn it over to Mike Baxter to give an advocacy update real quick. Mike, you're on mute.
Sure, thanks, Mitch, and I won't keep everybody waiting because I know we're eagerly anticipating these votes. If everyone remembers, the original authority to provide COVID-19 vaccinations stemmed from an act of the federal government coming from the HHS to order and administer the COVID vaccination. Most recently, about 2 weeks ago, the president came out with his path out of the pandemic. 3 major items for pharmacists included there. An extension of the PrEP Act, which is the original act that granted liability coverage to order and administer the COVID-19 vaccination, was extended to now administer COVID-19 therapeutics. So that's very exciting. That includes the monoclonal antibody therapies. It also includes additional therapeutics in the future, which could be oral. So we're very excited about that. And this really is the test and treat model that we've been trying to aim for all this time, and moving us closer to provider status. Second point there, you can see that was included is an expansion of testing is going to be coming out with 10,000 additional retail pharmacies. So we'll keep people posted on that and where that's going to be happening and the locations of facilities. And also the booster shots, which we're talking today, obviously incorporating all direct pharmacies, not only through the retail program, but also through all independent pharmacies. So really using existing distribution chains to get the more vaccinations out there and as the boosters are approved by FDA. And you can link to the plan there. If we go to the next slide. Sure, and rather than, since we're running out of time, I wanted to include, you just provide a link. Here's a link to everyone that you can provide a lot more information about the 9th Amendment and all the requirements to meet it. I wanted to draw your attention really quickly to the training requirements here that you can take to be authorized to order and administer therapeutics right now, including the all-important monoclonal antibodies. And you can see the 2 links there to the certificate program and also the therapeutic training for monoclonal antibodies. And with that, I'm going to turn it over to Meg, if she can come up, and she's going to go over a couple of our new updated resources.
Thanks, Mike. Yeah, so in response to this new authority, we have updated our webpage on COVID-19 therapeutics, and the chart that was just on the screen can be found in this resource here, Authority to Provide COVID-19 Therapeutics. So we recommend that you guys visit this page and get the latest information there. We also have sort of a backgrounder and an overview of the monoclonal antibody therapies that are available, things you should consider, and some of the different opportunities for pharmacists described in that resource. So a lot of new things there. And then we have the exciting new free training program that Mike mentioned, which is designed to help fully satisfy the requirements under the PrEP Act to administer subcutaneous monoclonal antibody therapy. So recommend checking that out as well. And then lastly, we've talked a lot about vaccines today. So just a quick reminder that we do have several resources and places you can go to get information around this. We've got our COVID-19 vaccines page, and then of course our Vaccine Confident microsite, where you can find a bunch of information about how to talk to your patients about the vaccines and encourage them to get vaccinated. Finally, I'll just make note that we will be posting some updates to Engage, and if you haven't been on Engage, we highly recommend you continue the discussion there. This is for members, and we will be updating and keeping our members in the loop as we learn more over the next couple of days. So with that, I'll turn it back over to Mitch.
Thanks, Meg, and thanks, Mike, for the great information. Next slide, please. Just what Meg talked about in terms of the training program that we have on the monoclonal antibodies. That, along with your immunization training program, will satisfy the education requirement for the PrEP Act. Our next webinar is scheduled for October 14th from 1 to 2. The topic will be on COVID-19 therapeutics update. We'll delve into the ivermectin issue as well as the monoclonal antibodies that Mike and Meg talked about, as well as you can imagine, any other breaking news regarding COVID-19 vaccination and treatment. I will now turn it back over to John Gravenstein to give us the latest and greatest out of ACIP. So John, you're on.
I feel like one of those election night people on, on one of the cable channels. This is pretty cool. If we can run back to that slide with the 1, 2, 3 options, please, Meg. And thanks to Meg and Brian and all the backroom folks for making all this work so smoothly. It's really cool. Next time, can I get a map? No, that'd be nice. They just voted down policy question number 3. It was 6 in favor, 9 against. So what the news will report tonight is 65 plus long-term care residents, all of them, Pfizer vaccinated, get a 3rd dose of Pfizer. 50 to 64 underlying medical conditions, all of them. 18 to 49 underlying medical conditions, individual risk benefit, talk it through. It's the old shared clinical decision making or permissive, or those old words. 4 was voted down. There was discussion of rewording it and revoting it. It has to do with that point I was making earlier of there's not really evidence of waning by occupation or by setting, and it's based on those other things. And so why would you boost them if they should be? I should be doing just fine. So the comment was made, we're not going to reword and revote today because they're tired. And so the next ACIP meeting is September 29th. Be there, or you can watch it live on the internet and watch the sausage being made. Thank you.
Okay. Thank you, John. Again, thank you everybody for being on this call, for everything you're doing in your communities and your practice. Stay safe, stay in touch, and we'll keep you informed as things progress in this area. Thank you again for spending your time with us.